Welcome to Let's Talk Wellness Now, where we bring expert insights to you. Please note that the views and information shared by our guests are their own and do not necessarily reflect those of Let's Talk Wellness Now, its management, or our partners. Each affiliate, sponsor, and partner is an independent entity with its own perspectives. Today's content is provided for informational and educational purposes only and should not be considered specific advice, whether financial, medical, or legal. While we strive to present accurate and useful information, we cannot guarantee its completeness or relevance to your unique circumstances. We encourage you to consult a qualified professional to address your individual needs. Your use of information from this broadcast is entirely at your own risk. By continuing to listen, you agree to indemnify and hold Let's Talk Wellness Now and its associates harmless from any claims or damages arising from the use of this content. We may update this disclaimer at any time, and changes will take effect immediately upon posting or broadcast. Thank you for tuning in. We hope you find this episode both insightful and thought-provoking. Listener discretion is advised.
What if I told you that before a single drop of chemotherapy goes into a cancer patient's body, we can take a blood sample, grow their actual living cancer cells in a lab, and test 70 different drugs against those cells, all outside the patient's body, to find out which ones actually work? And what if I told you that the conventional oncology doesn't routinely use this test? Well, today we're going to talk about why that matters. And we're going to go through and I'm going to share a story that is very personal to me. It's about a 38-year-old man with a rare complex cancer diagnosis and the precision testing that is helping to keep that cancer from progressing. Stay with me. This is one that is going to change how you think about cancer treatment.
Tired of being told your labs are normal, but you still feel terrible? At Serenity Healthcare Center, we don't chase symptoms. We find the root cause. Hormones, gut health, autoimmune conditions, chronic fatigue, brain fog. We use cutting-edge functional and regenerative medicine to get you real answers and a real path forward. This isn't your average doctor's office. This is medicine the way it was meant to be practiced. You deserve to feel like yourself again. Visit serenityhealthcarecenter.com to book your appointment today.
Hey, everybody. Welcome back to Let's Talk Wellness Now. I'm Dr. Deb, and today we're going deep. I mean, really deep. Into some of the most cutting-edge cancer testing I have ever seen in clinical practice. Now, normally I don't talk about cancer, and I would not be sharing this story if it was anyone other than my own family. I do have permission to share and talk about this publicly, so I want to do this. I want to make sure that I share this message. And he is giving his blessing to share this story because we both believe that it can save lives. So his name is Cameron. He's 38 years old and he is my son-in-law. And 2 years ago, he came to me with a small lymph node underneath his arm and a bullseye rash. So of course, being the Lyme literate person that I am, my first inclination was to say, yeah, this makes sense. You have an enlarged lymph node because you have this bullseye rash. You got bit by the tick. Let's keep an eye on it. If it doesn't go away, let me know. So fast forward a year and a half later, he comes to me and says, Mom, what do you think about this? This thing is getting a little bit larger. And I said, yeah, it's a little larger. Not sure. Let's keep an eye on it. He wasn't feeling anything. All his labs looked okay. And then one day he was out chopping wood and he started getting numbness in that arm and he felt it again and it had exploded in size. And so after some evaluation with my daughter and him, we decided to do a ultrasound and we thought what was going to come back was a fatty tumor. It felt like one, looked like one, responded to one. He's 38 years old. He's healthy. There's nothing in our mind that's ever thinking the result that we're going to get back is a possible lymphoma. Needless to say, we were shocked by that ultrasound result. And we go fast forward, we have the biopsy. I requested a total excisional biopsy. I was told by the oncologist that that was old school. They don't do that way anymore. And I need to stay out of this. I need to let the experts take care of this because that's what they do best. And this came from a breast surgeon here in Wisconsin. And so I stepped back for a moment. I let him do his biopsy. And what came back was adenocarcinoma of an unknown origin. Had we excised the entire lymph node, we would have had more tissue to work with. I think we could have gotten a better diagnosis. So over the course of the next 2.5, 3 months, we have some more imaging done. We have some more testing done. They send a pathology out to Mayo Clinic. And what continues to come back is this incongruent test results. If anybody's ever had this, it's extremely frustrating. One test shows lymphoma. Now it shows breast cancer. Then the next week it shows estrogen receptor, HER2 positive breast cancer. 2 weeks later, another test comes back and it says, no, it's not HER2, it's triple negative breast cancer. And now it looks like it's out of the lymph nodes. Now it looks like it's in the lymph nodes. And we do a PET scan and they can't find cancer anywhere except in this axilla area. But now we find a lymph node on the right side, so it must have spread. Let's go ahead and do a biopsy on that. And so they biopsy the right side, and the right side comes back with nothing other than tattoo ink. Now, all of this is kind of crazy. I want to start by saying that I am not a cancer specialist. What I am sharing today is from a mother-in-law's perspective, from a medical detective's perspective. I do know how to do research. I do know how to find answers. And so what I'm going to share with you is totally my opinion and totally my experience. And I am not telling anybody to do anything different than what their doctors are telling them to do, but I am telling you to ask questions. So I go deep down the rabbit hole and find out that tattoo ink can appear like metastatic cancer on a PET scan. And we all know everybody gets tattoos today. They're all over everyone. And yet we're not thinking about how this tattoo ink can cause problems for us down the road. Not to mention that there are heavy metals in them and it's a toxin and it's creating an inflammatory process in your body that your body's constantly trying to get rid of. So the surgeon says to us, well, yes, that's normal that lymph node's inflamed. It's normal that there's tattoo ink in it. The body's doing what it's supposed to do. It's trying to get rid of a toxin. Okay, I will agree with that. But my son-in-law is covered with tattoos everywhere. And why didn't we mention the tattoo ink that was found in the left axilla? We are only mentioning it in the right axilla. So there's a lot of controversy, a lot of confusion. Many of you would never know any of this because A, you either don't look at your lab results, and if you do, you don't understand what you're looking at. And that creates a problem for us, right? You don't know what questions to ask. So we go into the doctor and the doctor tells us you have cancer and we're going to swoop you in. And in the next 2 weeks, you're going to be doing chemotherapy and radiation. And 6 months from now, we're going to be doing surgery. And there's no time for questions and you're scared shitless and you're just doing what you can to survive. And I get that. And I totally understand that. And I appreciate that. But I'm telling you that if that is your choice, that is your choice. But as you're doing that, take the time to ask the right questions. When this happened to us, there was a lot of challenging things with the oncology team. Nobody bothered to allow them to be a partner in their care. They dictated their care, but didn't allow them to be a partner. So here's what most oncologists do when patients get a cancer diagnosis. They look at the tumor type, they look at the stage, they look up the NCC guidelines, the National Comprehensive Cancer Network, and they follow the algorithm. Now, I have an enormous respect for conventional oncology. I really do. Working with cancer is probably one of the hardest things in medicine that anyone can do. The advances in this field over the last 10 years have been remarkable. But here's my issue. Standard treatment assumes your cancer is the same as the cancer in the clinical trial that created the guidelines. It's assuming that you and your cancer are the exact same as everyone else. You are the unique fingerprint, not the cancer. And this is the problem. Because your cancer is unique, just as unique as if you had your fingerprint taken, the mutations driving your tumor, the drugs your cancer cells are sensitive to, the metabolic vulnerabilities of your cancer, these are all different from the person sitting next to you in the chemo suite that has the same triple negative breast cancer or HER2 positive breast cancer or prostate cancer or colon cancer that you have. So what do we do about that? Well, in my world, in the integrative medicine world, we test precisely, intelligently, with the tools that most oncologists have never heard of. Or if they have, they haven't incorporated it into their treatment modality for a variety of reasons. Either it's not acceptable by the organization that they work for, they don't understand it, they're not going to be able to change their protocol anyway because they have to follow the NCCN protocol, so they don't do it, or they use a portion of it and they don't do anything outside the protocol. So today I want to cover 3 things with you, 3 tools that we used that I think every cancer patient should be asking for when they start treatment, or wherever you are in treatment at this point, you need to have these tests done. I don't have any affiliation with any of these companies. I don't get paid to tell you any of this. So let me just start by saying that. I understand the chemistry behind these and how important it is to give you precision cancer treatment. And that's why I'm talking about them today. The first one we're going to talk about is the Northstar Response. This is your cancer surveillance score in the blood. How much cancer is circulating in the blood? The Northstar Select, your cancer's genomic blueprint from a blood draw, and the DATAR Cancer Chemo-Scale, the live cell drug sensitivity test that tells us which drugs actually kill your cancer. So let's go. Let's dive into this. So what is all of this? Okay. The Northstar Response is a test that was developed by a company called Billion to One. And yes, that name is intentional because of the precision involved. It's a next generation sequencing test, meaning it reads DNA at an incredibly detailed level. And it looks at something called methylated circulating tumor DNA, or methylated ctDNA. Now, let me break this down in plain English for you because this can get a little overwhelming. When the cancer cells die or shed, they release tiny fragments of DNA into your bloodstream. We call this cell-free DNA or cfDNA, and it's hidden within that cell-free DNA. And there are fragments that come from tumor cells. We call those ctDNA or circulating tumor DNA. Here's what makes Northstar's response different. Rather than just looking for mutations in that tumor DNA, which is what most liquid biopsies do, and a liquid biopsy is just a blood test, this test looks at something called methylation patterns. Think of methylation like a dimmer switch on a gene. In healthy cells, certain genes are switched on and off in a very predictable way. In cancer cells, those dimmer switches go haywire, and cancer DNA has a characteristic hypermethylation, meaning switches are turning on and should be off, or off and they should be on. And these patterns are essentially a cancer fingerprint in the blood. Now, the Northstar Response scans more than 2,000 locations in the genome for these cancer-specific methylation patterns. And then it adds them all up into a single number called the Tumor Methylation Score, or TMS. So for Cameron's blood, which was drawn on April 20th, 2026, his baseline tumor methylation score came back at 13. Now, here's the critical thing. To understand this was his baseline test, his starting point. And the real power of this test is in serial monitoring, meaning we run it again and again and again over time. And if that number goes up, the cancer activity is likely increasing. If it goes down, we're likely suppressing the tumor activity. And if it stays flat or falls, that's telling us that the disease is responding. So this is now in the blood. We have an actual fingerprint, and every test from here forward will be compared to this number. Now, let's talk a little bit about this because I was not familiar with this test at all. I wasn't sure what to expect. I wasn't sure what to do with it. I did not order this test. He's working with Invita Medical and they are fabulous over there. I will tell you that from the beginning. This is coming from a practitioner and from a mother-in-law. They were absolutely wonderful to us. So when I saw this Northstar, I didn't know, should it be 0? Should it be 100? And when I talked to the doctor, he said, this number is actually really good. An average person walking around who's never been diagnosed with cancer, who doesn't have cancer, their number will be between 75 and 100. Cameron's was 13. I think that's fantastic. But what was the first question that went through my head? It's probably the same question that you guys are doing. How can he have cancer with a number of 13 when it's less than the normal average? And if we're supposed to use this to track what's happening with his cancer, how are we going to do that once we remove the cancer? Is this number going to go to 0? And it could possibly do that. And we may not be able to use this to track whether or not the disease is actually gone. But what we can do is use this to track over the course of his lifetime to see if the cancer cells are coming back long before we detect them on imaging. And that's the huge part of this. So this is not a test that just anybody should go out and get because you're worried about cancer. It is a test that should be done in somebody that is already diagnosed with cancer. So let's start by making sure we explain that, okay? So imagine if every time your cancer cells are active and they're shedding and they're multiplying and they're fighting back, they're leaving a signature in your blood, not just any signature, but a specific chemical tag that says cancer's here. That's what the Northstar Response test reads. Those tags across thousands of locations and gives us a single score. So we track that score over time like a thermometer for your tumor. If it goes up, we get concerned. If it stays stable or goes down, we celebrate. And we can catch a change in the blood often months before it will show up on a scan. Pretty important when we're talking about surveilling somebody for cancer returning, when we're worried about it. And everybody knows the cancer patient is always worried after they get that clean bill of health that something's going to come back. And most of the time they're told that there is no way for them to determine that or know that from a blood test. And here is the blood test that can tell us, yes, it can. So I would really encourage you guys to talk to your oncologist about this. If you can't find an oncologist that will do this, talk to an integrative cancer doctor. They will most likely be familiar with it. If not, ask them to find it for you and order it for you. So next, let's talk about that genetic blueprint, because Northstar Select is a different test, also by billion to one, run on the same blood draw, but this one is doing something completely different. This is a comprehensive genomic liquid biopsy. Liquid biopsy just means blood test, meaning it's looking for specific mutations in 84 cancer-related genes, all from a blood sample. No biopsy needle, no surgery, just a blood draw. It looks for CNVS, single nucleotide variants, tiny one-letter typos in the DNA code. It looks for indels, small insertions or deletions in the DNA. It looks for copy number changes, the sections of the genomes that are duplicated or deleted. It looks at fusions. So when two genes incorrectly link together to create a dangerous hybrid, MSI status, satellite instability, which tells us whether immunotherapy is likely to work. And it has extraordinary sensitivity. It can detect a mutation that represents as little as 0.15% of cell-free DNA in the bloodstream. That is an almost impossibly small signal in the ocean of genetic noise. So what did this show for Cameron? This is where Cameron's case gets clinically fascinating and where it tells the story of how his cancer is being held in check. Two major mutations were identified as actionable. One was called CRAS, and it's a variant allele fraction at 0.1%. Now, KRAS, if you've spent any time in integrative oncology, you've heard this name. KRAS is one of the most well-known oncogenes in cancer biology. Think of it like an accelerator pedal in the car. In a healthy cell, KRAS pushes the cell to grow when it receives the signal to do so, and then it stops. In cancer, KRAS gets stuck in the go position, like on the accelerator, foot on the accelerator, to the floor, going as fast as you can around that track, right? But it's stuck there permanently. It doesn't turn off, and it's supposed to be turning off. The G12C variant specifically is a mutation at a very precise location, position 12 of the KRAS protein, where a glycine is replaced by cysteine. And this matters because KRAS G12C is now a druggable target. There are FDA-approved drugs specifically designed to lock this mutation into its inactive state, essentially putting a foot on the brake. Now, those are drugs like, and I'm going to slaughter these names, Sortisib, a brand name is Lumakras, and Atacras, the brand name is Crastal. Neither is yet FDA approved for breast cancer, but they are approved for lung and colorectal cancer with KRAS G2C. And Cameron's test identified 10 active clinical trials within a region that he could potentially qualify for with this mutation. The fact that his KRAS G12C is circulating at only 0.1%, that is a very low fraction. We call that a VAF, VAF, very low fraction, and it tells us something important. It means that this mutation is present in a small subclone of the tumor. It's not the overall tumor burden. So either way, what we identified, we know it's there, we can catch it, and we can watch it. Now, here's another interesting thing that we saw. His TP53 was at 0.23%. This is a tumor suppressor gene, the guardian of genome. And this gene is responsible for telling damaged cells to either repair themselves or self-destruct. And when it mutates, as it is here in the position R196Q, that guardian goes off duty. The cell no longer has a reliable mechanism to prevent uncontrolled growth. So TP53 mutations are present in roughly 50% of all human cancers. And there is currently no FDA-approved drug directly targeting the TP, but there are clinical implications. TP53 mutant tumors may respond differently to chemotherapy, and several investigational approaches, including TP53 vaccines and aurora kinase inhibitors, are under active investigation. So we are seeing things happen in this part of cancer right now. Now, there's something called the VUS list, and we are watching. This is what we're watching. So beyond those two actionable mutations, Northstar Select identified what we call variants of an unknown significance, VUS, adenocarcinoma of an unknown significance, ACUP. These are mutations where we don't yet have enough clinical evidence to determine whether they're driving cancer or not, but we watch them. So on our mutation list was CDH, a gene linked to hereditary gastric and lobular breast cancer, CDKN2A, a tumor suppressor, cell cycle regulator, CDK12 involved in DNA repair, EGFR, ERBB, this is HER2 receptor, tyrosine kinases. I thought this one was pretty interesting since he had an IHC that showed a 3+ HER2, but then when we confirmed it with FISH showed that was negative, but now we're actually seeing genes expressing this HER2. So is there a HER2? Is there not a HER2? This is really important because if we don't get these diagnoses right in cancer the first time, people will spend months and years treating the wrong type of cancer with the wrong type of medication. And this may be in part why some people do better than others. If we get it right out of the gate, they do good. If we don't get it right out of the gate, they don't do so good. Very important to have the actual genetic makeup of the tumor that's growing in somebody. Now, last, we have something called NOTCH-C1, NRAS, and RAF1. These are key pathway components. Now, all of these were at very low BAAHPs, under 0.5%. These are just whispers, not shouts, but whispers that this cancer is excreting. But your body is listening. We have to be listening. We have to be able to watch these things and monitor these. Now, here's another note of clinical interest. It was an androgen receptor positive cancer, so also detected as a VUS. We know from tissue pathology that Cameron's tumor was androgen receptor positive. So seeing this in circulation confirms that this AR expression of the cells are present in the bloodstream and that an anti-androgen approach remains worth considering. What that means is suppressing the testosterone. What all of you know I'm about ready to say is that I hate ever suppressing hormones, especially in a 38-year-old male. That is not necessarily a good thing. So before we go suppressing hormones willy-nilly, we have to know that it's the right thing to do. And we have to be able to combat all of the complications that are going to result of that. A 38-year-old male with no testosterone could lead to heart disease down the road, could lead to bone loss, could lead to dementia, Alzheimer's, not to mention the sexual side effects that are going to be present. And in a man, that is very, very difficult for someone to manage. So you have to be very specific and you want to be very, very diligent about what you're doing in these cases like this. Now, the MSI status was not detected. This tells us that cancer is not a microsatellite instability high, meaning that standard monotherapy may have a lower baseline response of probability. And the strategic integration that we're working with Invita could create an immunogenicity becomes even more critical. So immunotherapy is going to be very critical in a cancer case like this. And working with somebody that understands that and can carefully navigate that, especially if you have an autoimmune disease like Hashimoto's or lupus, this is all very, very pristine and has to be looked at very carefully and done very diligently in order for somebody to do this without overstimulating that immune system and causing more problems. So when we looked at the blood and found this DNA fingerprint of the cancer cells circulating in the body, from that, what we see exactly is the genetic switches that are stuck on. They're stuck on in the wrong position. This tells us which drugs were designed to fix exactly that problem. And it opens the door to clinical trials built for these specific mutations. It also gives us a list of things to watch for over time. And if one of those tiny little signals starts to grow, we know that cancer is gaining a ground in that area. And if it shrinks or disappears, we know we're winning. This is I cannot tell you how exciting this is in the cancer world and the medical world, because this is really pristine cancer therapy that we're dealing with here. And to be able to have this is just so important to life-saving events in treating cancer. So let's talk about something called the DATAR Chemo-Scale. This is the battle before the battle. Okay. So I've saved the most remarkable test for last, and this is one from a company called DATAR Cancer Genetics. They're based out of the UK. They are CAP and CLIA certified, which means it meets the rigorous standards required for clinical laboratory testing in the US. And this test is called the Chemo-Scale. And it is a live cell chemosensitivity assay. So let me explain exactly what that means, because it sounds complex, but the concept is actually quite elegant. When we drew the blood from Cameron, the DATAR's laboratory isolated what are called circulating tumor-associated cells, or CTACs. And these are actually living cancer cells, and they're associated cells that are traveling through his bloodstream. Excuse me. So let's think about that for a moment. Real, live cancer cells isolated from a blood draw. Those living cancer cells were placed into a lab environment and exposed to over 70 different drugs, both conventional chemotherapy agents and what we call repurposed drugs. And I'll talk more about those in a minute. The lab then measured how many of those cancer cells were killed by each drug expressed as a percentage of cell death. So the scale runs from 0 to 100, and below 25%, that drug doesn't work well against any type of cancer in that person. Might work great in somebody else, but in that particular person's cancer that they have, it's not going to work so great. Anything that's 25 to 50% is intermediate, and above 50% is a high response. And that's really where we want to be. We want to see anything higher than 50% because that's a great medication that can be used to kill the cancer. This is not a theoretical test. This is not based on tumor's genetic sequence and the computer algorithm that predicts the drug response. This is a HIS, actual tumor cell, being killed or not being killed in real time. That is the difference. So in traditional chemotherapy, we have our protocols. If you have triple negative breast cancer, if you have HER2 positive breast cancer, if you have prostate cancer, if you have colon cancer, here is the protocol that you're going to use because that's the type of cancer you have. That's what's been studied. Now, the problem is most of these cancers have mutated over time, especially depending on how long they've been in your body, because that's what they do to try to survive. They have to change so they can survive because your immune system's constantly trying to kill them. And so this is a really important thing. And if we don't take an individual into response or into our thought process when we're creating these protocols, we may give a drug that doesn't work at all towards that cancer. And you just wasted 7 cycles of chemotherapy with a drug that never would have worked in the first place or had such low resistance to it that it's now just created side effects for you, but did nothing to the cancer. And then we pull out another drug and we try that. Instead of us knowing precisely what we can use and what we can do. And this goes for both the conventional world and the alternative world. In the alternative world of cancer, we use things like IV vitamin C and turmeric, and lately ivermectin and fenbendazole and menbendazole and all kinds of other things. And if we are not truly aware that this is going to do anything, we could be wasting somebody's time and money. So I love that this test is available. I want to walk you through a little bit about what we saw in our case, because I think this can make a big impact on people to ask the right questions. This particular blood test looked at several different drugs. It had sensitivity from 44% up to 61% on different medications. Now, he was really lucky. The 3 main drugs that they would use to treat his cancer, he had greater than a 50% response to. So that was great. However, the drugs that were recommended for him to use out of the gate had less than 50% activity. So he would have had one drug that was really good, one drug that was not so good, and we don't know what the outcome would have been, right? So I think this is such an incredible test to have done. This is critical, friends. I'm telling you, if his oncologist had chosen the 2 drugs based on the general guidelines for his tumor, his cells would have largely not survived. But because we ran this test, we know to avoid the drugs that won't work. And we focus on the firepower where it really counts. So I want to also talk about this repurposed drug result, because this is where it gets integrated for us. Now, this section is what I want everyone in our community, our Let's Talk Wellness community, our members to understand. This is where conventional medicine and integrative medicine intersect in a peer-reviewed, clinical validated way. So the DATAR test looks at live cancer cells against what they call repurposed drugs, meaning pharmaceuticals and natural compounds that were developed for other purposes, like it could be an antibiotic, it could be an herbal medicine, it could be all kinds of things, vitamins, whatever. But they have demonstrated anti-cancer activity in research. And when we're talking about integrative medicine, this is a lot of where we get the integrative protocols from, because these particular drug compounds are known for having anti-cancer benefits. And so that's how integrative protocols get developed. But again, it could be just like medication like cancer drugs, if your body doesn't have a susceptibility to it, then you're using a product that's not necessarily going to work. And we all know we cannot take everything that somebody recommends just simply because it has an anti-benefit to whatever it is we're treating. There's only so many supplements you can take. There's only so many things you can do before you get burnt out on taking it. We call it supplement fatigue. And so we want to be very precise with what we're doing and target this very specific area. So one of the things that showed up really, really well for our case was artemisian, sweet wormwood. It's an anti-malarial drug that has very potent anti-cancer effects. Now, I found this extremely interesting in Cameron's case because he does have a positive tick-borne illness called babesia. And this is one of the things that we use to treat babesia. The other thing I think is very interesting in this case is we are studying how parasites affect cancer these days. And that's how ivermectin, fenbendazole, and menbendazole have all gotten thrown into the treatment of cancer. And so for this drug or this herb to be sensitive to this type of cancer is really intriguing to me in the world of parasites and how parasites are truly decreasing the body's immune system and causing cancer to grow. Another thing that showed up really well for him was valproic acid. It's an anti-seizure drug with HDAC inhibitor properties, and this disrupts cancer cell gene expression. There was a soy formula that showed up really well. Naltrexone, you guys have heard me talk about low-dose naltrexone, LDN. This actually stimulates an endogenous opioid immune response feeling, and this drug actually showed up really well. Something as simple as quercetin. It's an anti-inflammatory. This is a KRAS inhibitor in some studies. So this is really important. I'm sure most of you have heard about the benefits of green tea, and green tea also actually has anti-angiogenic or anti-cancer benefits to it. Hydroxychloroquine, very popular drug, is another anti-malarial drug. So again, now we have two anti-malarial drugs that are susceptible to this type of cancer. And on top of it, he has a positive babesia test. So just saying, you got to connect the dots sometimes. You got to think outside the box sometimes. Metformin is very well known as a anti-proliferative in cancer. We use it to suppress the sugar because sugar feeds cancer. Nobody should be eating sugar if they have cancer. So this one showed up as well. And then CBD. We all know of the benefits of THC, the Rick Simpson oil, and CBD can be tested to see if that is beneficial to a particular cancer cell. This is different than THC. THC works very differently in cancer. CBD is your healthy component of it. It's the part of the marijuana plant that does not make you high. So very important here. So now let me be very clear, because I always try to be very clear. This is not FDA approved. I'm going to repeat that. This is not FDA approved. This test is a laboratory developed test, not FDA cleared. These results represent in vitro testing, meaning in a lab, not inside the human body. And the results can differ in what we call in vivo, inside the body. And this is why I always say, work with a qualified clinician who can interpret these results in full clinical context. But here's why this matters. We now have evidence, live evidence of a cancer cell that shows sensitivities to compounds that are accessible, relatively safe, and some of which he may already be using. We were already using some of them, which made us sit back and say, this cancer's been in there for 2 years. If it's a triple negative breast cancer, it's supposed to be an aggressive breast cancer that should have spread to a different organ already after 2 years. It is not. It has stayed in one spot. Also interesting in this case is that there is no breast tumor that they could find anywhere. This was all confined to the axilla and to the lymph node. So to have this growing for this period of time with such a small tumor marker number, that 13 that we talked about in the Northstar test originally, and to see some mutations, there's a lot of questions to this particular case. And there are lots of questions to everybody's cancer case. They are not all straightforward cancer cases. So This is what's important to understand, this fingerprint of these cancer cells, so that you can identify exactly what's going on and treat it exactly the correct way. Super important. So this kind of information gives us the direction in an integrative protocol. It's not guessing. This is not eat more turmeric and hope for the best. This is personalized, tumor-specific, precision-guided integrative oncology. It is very precise. There are several clinics like this around the country that offer this type of therapy. If it's something that you're interested in doing, I would encourage you to look at Invita Medical. Hope for Cancer is another great facility. There are several great facilities around the country, like I said, that could put together an integrative approach for you if this is something that you are thinking about doing, if you're looking for answers, if you're in stage 4 or stage 3 and you are not getting the results that you want to get, you want to look at a different approach. You want to do a combo approach of integrative medicine and traditional medicine and alternative medicine. I think this is so important to look at and have experts on your team. You know, in our case, Cameron's cancer is very complex. It's genomically aggressive in its presentation, yet it's not progressing to distant areas, which is so wonderful. And I want to be careful here. I can't tell you with certainty that this is any one thing. Biology is complex. Cancer is adaptive. It's trying to survive. That's what it is supposed to do. It is changing its shape. It's changing its genetic structure. It's changing everything to try to survive and try to hide against your immune system. Now, we are not even close to the finish line in our journey. But what I can tell you is that what the integrative precision approach has done, that standard care alone might not do. I can tell you that today, and I will share our journey along the way for any of you that are going through this that want to look at a different approach as well, because I think it's important to have this information. So first of all, we know the tumor's fingerprint. Northstar Response gives us that TMS score so we can track it over time. And if the cancer tries to gain ground, we'll see it in the blood before a scan will show it. We know the cancer's genetic vulnerability. We know how to handle the DNA now. We know the watch list of things to look for. And when those signals start to grow, we have a roadmap of how to address it next, how to change it. We know which drugs will automatically work against the tumor cells. We're not guessing based on a tumor type. We tested the cells. We know how many drugs in the commercial world and in the repurposed world will and will not work. And this is going to guide the treatment protocol that we walk forward with. So we're not giving him drugs that won't work or have a low response. We're avoiding them completely. And that matters because every ineffective drug is a dose of toxicity with no benefit. There is no lie to this. Chemotherapeutic drugs are toxic. That's how they kill the cells, but they kill the good cells and the bad cells. And if we can avoid using a drug that's not going to work, that is so important. And then we're layering in those repurposed and natural compounds with proven activity against specific cells. This is not complementary fluff. This is biologically active, tumor-tested precision medicine. Very, very important. So here is what I need you all to know and what I want you to walk away with today. If you or someone you love is facing a cancer diagnosis before treatment starts, before the first infusion goes in, I want you to ask these questions. So quick, go grab something to write with. Pause this if you need to, because this is really, really important for you to do that. And we're going to take a break for just a second while you guys go and do that. We're going to give you a word from our sponsor, and then we're going to come back and I'm going to give you the 4 questions that I want you to ask specifically of your medical team so that you have the answers and the ammunition that you need to work with. So we'll be right back. All right, everybody, welcome back. I hope you got your pencil, your paper, your pen. your phone, whatever you're going to take notes with, because this is important. So I'm going to give you 4 questions that I want you to ask your medical team before you get started. Question 1, can we do a chemosensitivity test before we choose a chemotherapy regime? Ask specifically about DATAR, cancer genetics, Oncostat Plus, or a similar functional chemosensitivity platform. Very, very important to ask those specific things. All right, question 2. Can we do a comprehensive liquid biopsy to identify actionable mutations and monitor tumor burden? Northstar Select by Billion to One, Guardian 360, or Foundation One Liquid CDX. Okay, question 3. Can we establish a baseline tumor methylation score, TMS? So we have a surveillance marker to track over time, and ask specifically about the Northstar Response test. All right, question 4. Is there an integrative oncology center that can layer precision-guided natural compounds alongside conventional treatment? Research institutes like Invita Medical Center, CTACA Integrative Medicine, or Hope for Cancer, these people are doing integrative medical miracles. Let me tell you, I have researched every one of them. I have spoken to each of them individually before we made our decision of who we were going to work with. They are all fantastic. You want to work with an integrative nurse practitioner who understands oncology. And if you're working with an integrative practitioner, you want to ask them these same questions about this test so that you can get the best outcome for what you're dealing with. You are allowed to ask these questions. You are allowed to want more information from that protocol that was designed for the average patient. You're not average, and your cancer is not average either. And your care doesn't have to be. You do not have to settle for the same thing that the person sitting next to you in the IV suite is dealing with when you both have different cancers excreting different genetic material. This is so incredibly important. I want to make sure you understand precision medicine is what changes the lives for people every single day, every single day. So I started this episode by telling you about a 38-year-old man with a cancer that baffled conventional medicine and integrative medicine, an occult primary that was not found, complex genomic profile, a presentation that in many hands might have resulted in a one-size-fits-all treatment protocol and a prayer. And instead, we ran the tests, we mapped the fingerprint, we watched the cells, we guided the protocol, and we are still fighting with precision, with data, with intelligence. This is what Let's Talk Wellness is all about, not giving up. This is what not accepting we don't know as a final answer, and demanding the level of scrutiny and personalization that every cancer patient deserves. So if this episode resonates with you, please share it, because somewhere out there, there is a person who is about to get the wrong chemotherapy because no one ran the right test. And maybe, just maybe, that this episode will be the reason someone asks the right question at the right moment. If you're going through something like this, you need a group, you need somebody to connect with, please join our free Facebook group called Seen at Last. It is where we support one another, we share this information, we share knowledge, and we help people for free support and ask the right questions. And if you're inclined in your heart to pray for Cameron. We could use every ounce of prayer. If you are in a position where you can help support this journey financially, we do have a fund going in Free Funder. I can post the link below. Every little bit helps. If you have $5, $500, it doesn't matter. We're raising money for this treatment. And along the way, I am documenting every step of what we're going through so I can provide more episodes like this for you guys to share the outcome and share what our journey is like so that it can help the next person along. I really always believe that whatever happens to us because we're meant to share it. That's why I've shared my personal journey. I'm sharing his personal journey, and we want to help other people. So until next time, I'm Dr. Deb. Keep asking questions, keep advocating, and never, ever accept being unseen.